Thank you very much. Assalamu alaikum. Good morning, everyone. Very happy today to share with our colleagues in cochlear team and audiologists our collaboration. And thanks for the organizing committee for inviting me for a nice conference. And I hope at the end of our speak today, we will have a nice discussion and comment how we can improve our program, national program in Saudi Arabia, and how we that can help our kids to get their treatment or surgery and rehab in a nice and frame time. So nothing to disclose, and Dr. Ahmed and our team, always we have a lot of discussion, and we talk about this program since long time, and as you know, it's part of very high safety to discover those baby very early and to give them what they need as much as they can in the time frame. So our program in Saudi Arabia starts in 1435 by royal approval from King Abdullah. As you can see, this letter from the royal department. And since 2015, we start to accept hospital in Ministry of Health to join this program. So we start in phases, the national screening program. In 2015, we start the phase 1, and we around almost 61 hospital joined the program, and the phase 2, another I think 70 hospital, and then at 2017, we complete all the hospital in Ministry of Health who have the service of delivery. So today we have almost 170 hospital having the service of delivery in Ministry of Health of Saudi Arabia doing the screening program. As you can see in the map how they are distributed between the regions in Saudi Arabia. So if your hospital is not doing this as a part of Ministry of Health, please talk to us later on so we can arrange that. So our program go through some of the steps. I think this is the whole journey of the program for the babies who's having hearing loss and need at the end some of the surgery or rehab. So they go through a pathway or some of the phases, and we take care of the phase number 1, and we have some rule in phase number 2, then at the end number 3 and 4 by our colleagues in the cochlear team. So phase 1 or the screening program, we have somebody representing the program in the hospital. So usually they start doing the test at 24 to 48 hours of delivery. If the baby is okay and he's willing for discharge by assigned nurse in the 170 hospitals, then they have website to enter some of the data and the result of the test either pass or they refer to the website. So once the data in the website, we have collaboration with Lean company. So they gather the data and they process it, and we together as a team every month we have some validation. So we send the report to the leaders and pack to the locations so they can assess how they are doing, how much their completeness, and how much what's the gap they have so they can improve themselves. Now this is the phase 1. And this is the steps we are doing in the phase 1. And today I try my best to share you what we are doing and what's the challenges we have and what's the solution. We did it together. So I was very committed that I hope we'll see a lot of audiologists in this forum and our ENT colleagues. So they should know what's the challenges we have it and how we spend time to improve our completeness of the test. So at the end of the day, we could catch a big number of babies for screening. So we have a protocol designed how the nurse or the one who is doing the test can do the protocol, then how he can interpret the result, and how he can enter those data in the website, then how he can decide this baby is discharged or refer to the second phase. So screening test challenges. So over the last, let us say, 8 years, we go through a lot of feedback and testing the result we have. So we have some percentage of inaccuracy of test doing, like how the nurse is doing the test. So we have some percentage that test accuracy needs some improvement. And we have, as you know, we don't have any registry how many babies today screen in Saudi Arabia. So and again, as you know, we have in Saudi Arabia, you have different sectors doing the services for the newborn. So we have some other sectors, either governmental or private, not doing the test. Either they have different protocol or they have different challenges, so they couldn't do the test. So what we did, so we try our best to improve the accuracy or compliance to link the test to the parent experience. So today, any parent in Ministry of Health, after their baby receive a test, so they will receive a text message that their baby received the test or need referral or he passed the test. And recently we had launched the Saudi Neonatal Registry, and inshallah that the screening program will be part of that registry. We have today cardiac newborn registry and hearing newborn registry and metabolic newborn registry. And again, with the help of our leaders, mainly the minister. So today it's very mandatory that this newborn screening program should be applied in other sectors in Saudi Arabia. So phase 2, it's the referral from the screener to the audiologist to do the final test or definitive test of APR. So in this phase, we have the referral from the screening, and we have appointment test, and then we have the result of APR. Then if this baby, again, he failed to pass this area, he need to refer to the cochlear team. So we have another challenges, and we try our best to solve those challenges. So we didn't have formal referral pathway, how we can refer to those audiologists. If this baby is lucky, he did his newborn screening and he didn't pass, and he need audiologists to do the final diagnosis in the same hospital, he will be very lucky. So they will refer intra-hospital. The challenges happen when we refer outside the hospital or outside the cluster or the region. So we miss some baby in this phase, unfortunately, and we start to do some workshop and exercise how we can catch all those baby. So we design a referral link. All our nurses who's doing the screening, they know this link. So they just put very simple data, and we catch those data weekly. So we start to track those baby who's need appointment by communicating with their parents. Did they receive the appointment? Did they go to the appointment or no? So we improve our pathway to catch those baby. So at the phase or at the level of APR appointment, I think this is shared with Dr. Ahmed always, that our center who's doing the diagnosis is not at the level what we want. At 2015, I remember it was around 15 center or less. I think it's improved now with time. And again, we have some challenges with the machine itself. If they need to diagnose it, some area need more than one APR machine. and they need more competency on that. So we did some exercise by doing some survey in the NICU level 3 hospital. So we have 32 hospital to know where is the problem. Do we have a problem with the expertise people doing the test? Do we have a problem with the machine itself? Do you have a problem in referral system? Then we start with Dr. Ahmed and our colleagues in the ministry to solve those problems by doing some training, by doing some KPIs to monitor those, and by assigning some specialists to some area if they have no expertise. This is the text it received by the parents if they have, if their baby receive a test. So we start some campaign and we distribute the knowledge between the parents that if you should receive a text that showing you that your baby receive a test for hearing or cardiac problem. If the parent didn't receive that, that means there is some problem. Here you can see the center who's doing the APR test, and I think this picture improved today. This is, I think, from 2021. The area with green circle, it's the area they have available audiologists, and the area with the orange one that they have either audiologist without machine or machine without audiologist, and the area with red zone, they have some challenges, and the area with white, there is nobody. So you can see in Tabuk and Najran in 2021 and Al-Ghariyat, there was nobody doing that test. So we concentrate in those areas to be sure that they refer in the expertise people beside them. I think this picture improved, and probably we will get some update with Dr. Ahmed soon with this one. So you can see here, I take those slides from my colleagues.
I'm afraid I have to tell you 2 minutes.
2 minutes? Yes, almost there. So you can see how is our clinics for the final diagnosis improve over years. And you can see I will leave those things because this is for your guys, how they are doing the referral to the cochlear team. Again, we have some problems, so we have manual referral. And you can see how the people or the babies improve receiving cochlear implant over years. And at the end, the age of receiving the intervention is improved because of the collaboration services. So this is, I think, Dr. Ahmed can correct me. I think we have 15 centers now doing the cochlear implant. And this is the report we are seeing at the end of every month. We share it with our colleagues in the locations and our leaders in the regions, how much we complete our newborn test and how much the gap and where is the gap so they can improve themselves. So 2022, our completeness improved over the time. In 2015, I remember it was around 35. So last year we have 81% almost. We can complete the test. Still we have 19% gap. And there is a lot of discussion around the gap, why it's this gap, why those baby didn't complete their screening on the time. So just some of the home message for my colleagues who's sharing us the program. You should feel proud what we are doing today in Saudi Arabia, and you should feel supported that the leaders and even at the level of the royal body that everyone support the screening. And we need to communicate very common, and screening is very important because secure their baby, and success is journey, is just not a destination. So some thanks for our colleagues who's doing the test and central teams, and for the company who's supporting us doing those screening program. A lot of thanks to our colleagues, the audiologists who's helping us doing the test for our babies, and a lot of thanks to the cochlear team and for the families. Thank you very much.
Thank you very much. I think we have to postpone the questions to later.
Can I have a quick question? One question.
Yes, sure.
Please. Because it's very important, because newborn screening, we have to be integrated so we can work more better. So my question is for everybody to know that it's going to be digitalized, all the referrals.
Yes, sure.
Which platform?
So if you are talking about the reports or the tests, so today we have a work with Lean company. So every audiologist or ENT in the region for phase 2, he will have the user and password. So as I told you last time, so we agreed now that we need those people in the centers who can do the second phase, so we can provide them with the user and password. So he will open the system like weekly according to his clinic, and he will receive the referral through this system. So I will take an example for Abha because Dr. Yahya is here.
Yeah.
So if he have one baby in Dhahran al-Janub, he's not past the screen, and the nurse will open the website and Lean and say this is the referral. So two things will happen. The one working with Dr. Yahya in Abha, he will receive the notification that this baby need final test for diagnosis, and the family will receive the text message that this baby with this MR number refer to Abha hospital to do the test. Please communicate, and they will put a number. So this is the second phase. It will be activated soon. We are just waiting for the people. We are looking who's the people we will communicate so we can create the user and password, and we will do a workshop for them to show them how they can do the website.
This is just for the Ministry of Health hospitals?
At this level.
Yes.
Yeah.
Thank you so much. You did a magnificent work in this entity, really. And I think once we are digitalize all the referrals and the information, I think this is a huge jump for us. Thank you so much.
I think we have someone who wants to comment.
دكتور أنا مسافر الحين as Sultanate Oman has started this program since 2000 just to share with you our experience, and we reach now to 99% of over all the country, not only Ministry of Health, because all private is connected with this program, armed force and others are involved. It is what you have started is very nice, and it is a start, but you have to take in consideration the registration of all families, and it's very important, and to take the family history, because we do ABR even if it is the result is passed for the family which they have history of sensorineural. And that's it. And the other thing, we have to repeat the screening test after 40 days if it is not passed, because some of the children, they might have otitis media infusion at the birth. So if it is in 24 or 48 hours is not passed, to repeat the test before ABR sending, because that will reduce the appointment for ABR. You know, same problem we have, the center for ABR is less and the expertise is less. So to be sure that these people, these children, they need ABR, to repeat the test after 40 days, and if it is again is not, it's not passed, to send to ABR. The other thing, the well knowledge and information for the parents, because maybe in the beginning they are passed, but after a few months they will start to have problems. And then that also very important, the mother knows how they respond of the sound of the child, whether he is responding to the sound, whether not. We have so many cases, at the beginning they were hearing nicely, and then after some time they start to not to hear. And that also is very important, that the mother has that perception that the child is not responding, so she has to go directly to the center where they can do ABR and confirm the thing. And inshallah, you will reach to the same what we have, but has to be expand to all the country. Wherever there is an delivery of is, then they have to have that thing in there. And training of the nurse should mandatory. Thank you, and all the best.
Okay, thank you, Dr. Ammar, for your insights. Now I'm going to present an interesting talk about remote checking in Saudi Arabia and Arabic language users, which was the first use of remote check in Arabic. Ms. Sahar Al-Dahesh, who is a senior audiologist and head of audiology at King Saud Medical City, is going to present this work. Thank you.
Thank you. Assalamu alaikum. Good morning, everybody. My talk today will be about remote checking in Saudi Arabia and Arabic language use. As we know, cochlear implant recipients require lifelong clinical support in order to maintain optimized hearing performance. Research has shown that most of CI users, their hearing performance tend to stabilize within 1 to 2 years, and majority of them who did have a follow-up check in a clinic might require no or very minor changes. So clinical visit for regular review may not always be necessary. That's why telehealth should be considered as a support of the ongoing care of CI patients. The first telehealth assessment tool for CI recipients is the remote check. It's developed by Cochlear Company as a remote care monitoring solution. It provides the option of CI user to complete a routine hearing review at home without the need to attend the clinic. It aims to provide a convenient and flexible care option. Who are candidates to be enrolled in the remote check? The age we can enroll from 6 years and older, and now we can enroll less than that by choosing some task, not the whole task in the remote check. Device compatibility, it is compatible with the Nucleus N7, N8, and Kanzo 2 sound processor, and smartphone compatibility, iPhone and Android, competence of the patient to use, or the parents to use the Nucleus Smart app, and the capability and motivation to complete the task, and of course if the patient is away from the clinic. So what does it involve? It involves a customized set of activities that will provide screening across the 4 main areas that we would like to check that that is okay, which is the physical site by taking the implant site photos, and also device status by checking the impedance, and device usage by checking the data logging, and the hearing performance through the questionnaires and the hearing performance test. By getting all this information, it will provide us as an audiologist or a clinician enough information to determine what is the next best action for this patient. The 2 tests in the remote check is audiogram and the speech and noise test. Audiogram test, it performs an aided threshold among the speech frequency spectrum. It is a geometric screening-based apps which show high retest reliability compared with the normal or the manual audiometry. So it is used to modify, it uses a kind of modified presentation method designed to optimize a self-assessment and maximize test reliability. For speech test, the speech test which is used in remote check is the digit triplet test, which is a speech perception test that is quick, easy, and self-administered. It is used in many countries as a cost-effective, large-scale public hearing screening tool, and it has many advantages that have been proved in several studies. It is available in many languages and adapted for smartphones and internet applications. However, it was not available in Arabic, so there was no Arabic version which could be used with the CI recipient. Cochlear had adopted an Arabic version of remote check, and in June 2020, King Saud Medical City and King Fahd Medical City collaborated with Cochlear clinical team to validate this Arabic version. The validation was done by using iPads and headphones among 40 normal hearing males and females, age group between 6 and 46, and it was done at 3 times at different noise levels. After that, the validation have been successfully completed, and it became a part of Arabic version of remote check. I would like now to share with you remote check experience at KSMC. We started in July 2020, so the first case was successfully conducted that time, and then 6 CI users using N7 sound processor were enrolled. The age was between 8 and 35, with a minimum 2 years CI experience. That time we used the English version. After that, we paused because of some obstacles, which is language. Arabic version was not available that time, and the age. As you know, most of our centers, the majority of our patients are pediatric, less than 6 years, so we could not include them that time. Device incompatibility and smartphone incompatibility. Not all the patients have the iPhone at that time. Also, majority of our old patients were using N6, which could not work with the remote check. And difficulty using technology for some patients. Later in 2021, we continued our pilot after we overcame most of these problems, and 17 recipients were enrolled in remote check. Last year, 2022, a remote check was considered as a basic part for CI follow-up protocol in King Saud Medical City, and a total of 33 remote check enrollments and baseline testing were sent to our patients. When we reviewed the cases, it revealed that 78% required no further action. And this was expected because most of the patients that we enrolled them, as I mentioned at the beginning in the candidacy criteria, they are more than 2 years experience, their age is above 6, and if they will come to the clinic for follow-up, after checking everything, most of them will need no further action. So it's just a routine check follow-up. Based on that high percentage, a new clinic was initiated lately for cochlear implant remote check as a kind of virtual clinic to be as a healthcare service at our center. From our experience, we found that remote check is a convenient way to facilitate effective patient triage, so you will know which patient need to attend, which patient need just to monitor, and it will minimize unnecessary in-clinic appointments. It will minimize the time spent on late or non-attending patients. Also, it is a quick help in emergencies, which is very important. Sometimes a patient who live very far and they could not attend, they have a problem, they will contact you or contact the coordinator, and you want to check that everything is fine. So you can get the basic information from the remote check. If it is urgent, you can ask him to come. If it's fine, you can manage it, and they can wait until their next appointment. Also, it will maintain regular communication between the recipient and the clinician, because there is an option to, if they will send a question or they have something, you will reply to them and give them your feedback. So this is from our point of view as an audiologist. What about the patients? Actually, we are working on studying the satisfaction of the patient to be documented as a study. But for now, the feedback that we received from the patient, they reported a good level of satisfaction and benefits, like they don't have to travel. It will cost them nothing. It will reduce the waiting time to get an appointment. The flexibility of appointment time, they can do it whenever it's convenient to them. It will reduce the stress of the patient, of the accompanies. You know, sometimes the whole family have to attend with the patient because they could not leave them in their city or their place. On the other hand, some recipients or guardians who control the remote check for their kids were not motivated to be enrolled, and some of them didn't complete the test. We found that some of the common reasons are the technical difficulties, not all of them confident to use the remote check. However, it's easy, but they need to learn and well instructed, so lack of adequate instruction could be a cause. And also worry about reliability of the test. As you know, not all of people trust technology, and some of them, they prefer the human interaction. They like to see you and interact with you and discuss with you about their case or about their kids. In conclusion, the demand of healthcare service is rapidly rising. Remote check is designed to provide a flexible, time-saving, and cost-saving care option From our experience and also real-world experience in other countries, it reflected the high potential of remote check in providing greater convenience for the CI recipients and for us as a clinician as well. At the end, I would like to thank KSMC team, especially the CI audiologist, and for Cochlear team for their technical support. Thank you.
Thank you very much.
السلام عليكم. أود صراحة في هذا الوقت أن نكرم الجمعيات العلمية. بالأمس لم يكن هناك تكريم للجمعيات العلمية، جمعية الأنف والأذن والحنجرة، وكذلك جمعية السمع والتخاطب. فدكتور رائد المطيري نائب مدير عام المراكز المتخصصة، والدكتور علي ضامن، نود تكريم الدكتورة شذا صالح رئيسة الجمعية السعودية للسمع والتخاطب.
Does anyone have any questions for Sahar? Okay. So thank you. You're actually perfectly within time, and maybe we can catch time. Okay. So it's now my pleasure to present Sara Al-Arefi, who's going to talk about factors affecting cochlear implantation outcome. Sara. Sara is a research assistant under the research department of MEDEL. Please welcome Sara.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good morning to you all. I would be pleased to present you with a quick presentation on the factors that affect cochlear implantation outcomes. Until it works, let me emphasize the importance of knowing or have not only a basic understanding, but rather a deep understanding of the factors that affect the CI outcomes. Because assuming that a patient or a caregiver comes to you at the clinic and asking you for your honest opinion whether they should implant their patient or their child or not, or even themselves, you need to have a solid ground of understanding on those factors, because this way you can recommend them and give them the recommendation based on give them a clinical judgment that is based on research and not only guided by an emotion or empathy to the child and their family. So, moving on to our first factor, which is the age at identification, intervention, and implantation. This has been reported in the literature before, and there's a great emphasis on this factor, but I would like to emphasize more on the identification and intervention, and not only the agent implantation. Because when we implant early, we have enough period to try the solutions before we do the implant. Maybe the patient would not need an implant, and we need, because of the time limit, we need to go to the CI decision quickly and have no time for the experiment with the hearing aids. So this is a strong predictor, and there's a study showed that children who were implanted prior to 12 months had a receptive vocabulary that was within the normal range of children with normal hearing. And this is great, actually, because even if they don't have the expressive language that is comparable to the normal hearing, the receptive language would give them ability to communicate with others. And also there's another study which showed that similar word learning abilities with normal hearing when they were implanted early. We say prior to 12 months, but actually there's a study who specifically compared children who were implanted at 6 months and at 12 months, and they found that significantly poorer results associated with children who were implanted at 12 months of age. And they found that there's a whole one standard deviation for each 6 months delay in the implant. So when a child is activated at 18 months of age, they will have one standard deviation global outcome delay compared to when they were implanted at 6 months, for example. But this factor, although important, is not as significant with adults because they have found there's a comparable performance of younger and older adults. And I chose this chart because it's easy to the eye to understand, although this is old study, but you can see here the blue, and the blue is the children who were implanted prior to 5 years, and the red is the children who were implanted after 5 years, and they compare the CAP and May score, and it's clearly that children who were implanted early have achieved better results. But when I say young, how young I mean? It is prior to 12 months, and is it really safe for those baby infants to be implanted early? Actually, it is, and there were two studies where one of them had a large cohort of 73 infants and found there were no serious complications for the children. Jumping to our next factor, which is the duration of severe to profound hearing loss, or as we call it, the auditory deprivation. Lengthy duration of deafness, which is more than 20 years, has been a predictive of limited word recognition score for a long time. You can see the study I reference is it was done in the 90s. And one study from Green et al. In 2007 compared many factors, but found that the only factor that was shown to influence the post-implant sentence recognition was the duration of deafness. However, the better speech recognition with a cochlear implant there was peer-reviewed research anecdotal clinical experience that suggested long-term deaf adults often achieve better speech recognition with a cochlear implant than they do with hearing aids. So we still have to consider them for implant. And here you can see the BKB sentence score according to the duration of deafness in years. You can see before the 20 years, we have almost perfect scores, and after 20 years, we have almost 0 scores for the BKB test. And this is 117 adults, by the way. Now we have the etiology of hearing loss, and this is a huge field that we cannot explain in one slide. For this reason, we gathered or collected many etiologies and tried in a tiny infographic and indicated the positive or the expected outcomes with the CI for different etiologies. So we have ototoxicity and Meniere's disease and genetics, as well as advanced otosclerosis and sudden idiopathic hearing loss, as well as cytomegalovirus hearing loss. These are usually correlated with positive outcomes when they are implanted with a CI. On the other hand, the meningitis and acoustic neuroma, temporal bone fracture, and cochlear nerve deficiency or aplasia have been correlated with a negative CI outcomes. And as for the auditory neuropathy spectrum disorders, this is a question, and there's a huge debate in the literature whether they should be implanted or not. And I couldn't come to a conclusion, so we need to go to the research for and study each case in details to have a decision. Prior use of hearing aids. It was proven that the negative effects of auditory deprivation was partially offset by the consistent use of hearing aids. Coming back to our first factor, we do have to identify the hearing loss early so we have enough time to try the hearing aids. And the prompt provision of well-fitted hearing aids is critically important at the onset of mild and moderate hearing loss. Anatomy of the cochlea. So all cochlea, even the normal cochlea without malformations, are different. There are no identical cochleas. The right and left cochlea are different. And for this reason, there were different electrode types that was produced to use each with each specific case. This will have the outcome later would be dependent on such the electrode used in the surgery. Some of them are stiff, some of them are malleable and could be used with certain cases. Maternal education. We all know that mothers tend to spend more time with their children, so this has been recently studied in the literature, and they found there's a positive correlation with with the outcomes of the cochlea. Paternal education is also important, but maybe not as important as the mother because, as I said, the mother spends more time with their child. Now, cochlear coverage. In the recent years, there were these studies that have found the positive correlation between the angular insertion depth and the performance of the CI. You can see there are different electrode types and different degrees of insertion, and they all have come to the same conclusion. As for the electrode length, the longer the electrode, the more coverage that it will have for the cochlea. So you can see flex 20, flex 24, flex 28. Yeah, as I said, you can see the flex electrode length. The longer the electrode, the higher the percentage of cochlear coverage it will give us. And this is an important factor because it will affect later, and there are many studies, not only one, but I only mentioned one here, that have found a positive correlation with SDS scores according to the length of the electrode and the cochlear coverage. The wearing hours. There was a recent study by Al-Habib et al. That mentioned there's a cutoff point for children to have acceptable language development. And by acceptable, I mean SDS scores that is above 60%. And they have found that when the cutoff point in their study was 8.3 hours per day to achieve this level. So there's a positive correlation as well. And you can see here, the longer they wear it and the more they wear their processors, the better results they will have in the speech discrimination test. And the cutoff point is 8 hours, 0.3. Mode of communication hasn't been discussed heavily in the literature, but there was a study which indicated that 70% of the children who didn't use the sign language developed age-appropriate spoken language abilities. For this reason, we have to emphasize to the families, and this is probably the oral rehab part to put a light on this factor, because if they use the sign language, 39% of the children developed age-appropriate spoken language compared to the 70% of the children. And it has been proved by Gears et al. That the sign language delayed the processing skills, which are fundamental for speech, language, and literacy development. There are so many other factors which I don't have time to discuss, like the socioeconomic status, the comorbidities, the bilingualism, and the attendance at audiology appointments. But I would like to shed a light on a recent study from the University of Ain Shams, and it was published in 2023. They tried to utilize the artificial intelligence to give us an objective judgment rather than a subjective judgment of the factors and the variables that will affect the outcomes of the CI. And you can see the two most important factors are the auditory deprivation, as we discussed, but surprisingly, the other factor is the family support. And the importance is huge compared to the other factors that we have here, even for the age at implantation. So this study worth mentioning and worth going in deep. And thank you. By the way, the goal for us actually from the cochlear implant is not to only have a detection for the sounds, but rather to develop a language by which the children will communicate and have higher quality of life.
Okay.
And thank you.
Okay, thank you. Thank you very much, Sarah. May I comment a few things? Regarding etiology, I think you try to summarize it.
Yes.
Just to help you summarize it, if etiology affects the spread of current within the cochlea, such as meningitis, ossification, calcification, then it will definitely affect, or even the fracture, it will definitely affect
So they can be grouped in one now.
negatively the performance with cochlear implant. So any pathology in the cochlea. Regarding ANSD, there's actually at the moment no dispute that we should go for cochlear implantation, just for clarification. It's just that some consider more evaluation to see if it's pre-synaptic or post-synaptic. But no one says we're confused whether we should implant or not.
Okay.
Yeah. So I just had to clarify that.
Okay, thank you.
And family support, we did a study at King Faisal Specialist Hospital Research Center a long time ago. Unfortunately, it wasn't published, but the initial statistics showed that the highest predictor of performance was family support as well.
Yeah,
Okay, thank you.
I should quote that next time.
That's okay.
Thank
Any
you.
questions? Okay, thank you. Okay. So now we go to our next speaker. Dr. Midhat Youssef, who is a consultant audiologist, King Abdullah Ear Specialist Center, and actually my colleague, is going to talk about the Saudi PSI test. Please welcome Dr. Midhat.
الكمبيوتر مشتغل. شكرا دكتورة شذا. Thank you for the organizing committee for inviting me to be here today. So my talk today will be about one of our achievements in King Abdullah Ear Special Center. Recently we developed a new test for speech assessment called Saudi Pediatric Speech Intelligibility Test. So the speech audiometry, as you all know, one of the crucial and very important testing we use as audiologists to evaluate our patients at all levels of evaluation, either just general audiology, pre-operative, post-operative, candidacy for intervention. And the speech audiometry usually includes the speech reception threshold and the speech discrimination score, And for each test, we use different types of materials. And why we use speech audiometry, it has it has a lot of rules. Number one, diagnostic rule to confirm the pure tone finding, and then the site of lesion as retrocochlear pathologies. In central auditory processing disorders, all tests, almost all tests depend on different types of speech testing. And in functional hearing loss or pseudohypoacusis, it's very mandatory or very helpful to avoid or to diagnose those category of patients. Also, it has therapeutic role to plan and to evaluate the patients for different types of rehabilitation, for hearing aid selection, verification, and validation. And for our main talk today, the cochlear implant candidacy, one of the cornerstone is the speech discrimination testing. And also, after the cochlear implantation, the performance evaluation depends upon the speech discrimination testing in different levels of after implantation. What is the materials we use? We use monosyllabic words like what we use in speech discrimination, bisyllabic words, which we use for SRT, and sometimes we use sentences, numbers, environmental sounds, many different materials we can use for speech audiometry. And according to about the mode of presentation, we have the open set versus the closed set. Open set means that the patient has no lists to choose from. The closed set means the patient has a list to choose from what he hears. Live versus recorded. Live, what we usually use or do in every day in audiology. The examiner asks the patient to repeat after him. Recorded, when I can play a specific test, it's recorded through any mode of input to the audiometer, and the patient has to repeat after that recorded. And how I can administer the speech materials, anyway, either the headphones, insert phone, or loudspeakers. The usual way of mode of response is to repeat, sometimes 2 points if the patient cannot repeat in some cases, or to write down what he hears in some other categories. So what was the problem here in Saudi Arabia? So there was no validated or no recent validated Saudi speech test that could be easily used for adults or children. Second point, that's why we couldn't evaluate our patient in the proper way, either pre-operative or post-operative. That's on the clinical aspect. On the research aspect, we had a lot of reviewer comments about our research projects that we don't do proper evaluation for what we do. And our tools were very limited, I mean the Arabic speech materials. But that's not only the challenges we have. We started to implement some Arabic speech tests, which was standardized more than 30 years ago in different countries, like the Egyptian words lists. But the difference in culture, because the speech discrimination and even the SRT depends upon the culture and the familiarity of the words. The difference in culture and leads to unfamiliarity of a lot of words in the speech lists we used. Also, the difference in dialect between different countries led to a lot of problems, even for audiologists to properly pronounce the words. But we have more challenges with the hearing impaired children or hearing impaired subject. They have very limited vocabs, and increasing the degree of unfamiliarity and also decreasing the material used for them. They have a phonemic errors, so sometimes we cannot judge if they can correctly discriminate the word and correctly repeat the word or not. And this make challenges for us as audiologists to proper count the discrimination scores for them. For the cochlear implant children, usually they have some discrimination abilities before they can develop expressive abilities. So we cannot again judge if they can discriminate or not, because the very limited expressive abilities. Our cochlear implant patients, usually they are long life follow-up patients, and we have them starting from just sound detection until open set sentence repeating. So we should have different levels of speech test to be suitable for each level of rehabilitation. So what we miss for all those factors, it was clear that we need to develop speech test and material which should be related to Saudi culture and delicate and flexible in administration mode, so I can administer it in recording, in live, in any way, and different levels of difficulty, so I can use it with different levels of language developed by the patients, and suitable for hearing impaired subjects with limited languages and limited vocabs. It started the idea in 2019 between the audiology unit, speech rehab unit, and the otology unit in King Abdullah Ear Special Center, and we started to do our brainstorming how we can develop a new test in collaboration with Medel Research team, and ended by we selected a test called Pediatric Speech Intelligibility Test, which was developed in the United States in 1984 by the University of Texas. And why that test we selected? It could be used for children from age 3 to 8, which is the main age we have for our kids, and it includes words and sentence and depends on picture identification. So it can be conducted in different moods. And it was translated to Arabic version by Ain Shams University about more than 10 years ago now. So we have a lot of steps. I will not go in details, but it was very hard work actually to develop the test and to put it in the last version, or the final version. And after that, we recorded it. We make it as a recorded materials to be easy administered for the children. And after revision and the correction of the sound files, we started to develop the software. We developed it as Android-based. It is based on a tablet Android software. So through a specific IT company, and after a lot of steps with them, we had the final version of the Saudi BSI. What we have now, we have a speech discrimination test which include word lists and sentence lists, different moods. It can be administered in quiet, it can be administered in background noise, it can be administered in with competing sentence, which is the most difficult level of administration. So it has just a tablet, could be connected to any audiometer, and then the sound can be administered or through the loudspeakers or even the headphone, whatever I want. But to make it easy, we had another 2 versions on CD or DVD, because to make it easier for use if we want, and it has also a paper-based version of it. Some of the advantages of our test, it's automatic calculation, so the software calculates the percentage or the discrimination abilities of the child. Each audiologist can have his own account, so he can have his own data and all the statistics of his patients. Data saving, where the results can be retrieved from the website of the test, and also the website can do a lot of analysis to the test results for all the patients. This some pictures of the test software. This is the first page where you can choose what you want to do, and then what you want to, I don't know why it's not here, and the second page is to have the speech materials, which one, the sentences or why the picture is not on the screen? Excuse me? Yes, okay. So I have a small video to show how it works for our subjects.
السلام عليكم ورحمة الله وبركاته. هذا شرح مبسط لطريقة إضافة الأطفال وعمل اختبار لهم. نبدأ أولا في إضافة مريض.
The first step is to add a patient. So all the information should be added.
Number.
Some of them are mandatory, so we can retrieve the patient easily. مش عارف ليه الصوت ما بي
ميلاد. الجنس ذكر أو أنثى. رقم الجوال. البريد الإلكتروني. تمام. ثم الآن نختار الرايت اير أو الليفت اير. تمام. عندك الرايت في لوز. اختار نوع الجهاز. الآن حفظ. تم الإضافة بنجاح. هذه قائمة المرضى عندي. نذهب إلى ستارت تيست. نختار مثلا ستار. نختار الطفل. ثم نختار الليفل المطلوبة. كارد A مثلا. وهنا طريقة عرض الأسئلة، هل بانتظام متسلسلة أم بطريقة عشوائية. الأذن المطلوبة مثلا. ثم نبدأ الاختبار.
وين البيض؟
Here what the child should do just to choose and touch the correct pictures. If he chose the correct picture, the software will go to next question. If not, he will give him just 10 seconds as a trying period, and if he didn't answer, he will go to the next one.
قرد. وين الشعر؟ وين الوردة؟ وين القرد؟ وين البيض؟ وين الشعر؟ وين الفيل؟ وين الوردة؟
الآن تم الانتهاء من الاختبار. نذهب إلى النتائج. هذا الآن النتيجة 90%. نضغط على عرض النتيجة. هذه الأسئلة اللي جاوب عليها.
Here in the result section, it shows which one was correct, which one was not answered, which one was wrong answered.
السلام عليكم. خطأ. طلع لك النتائج. أيضا الإير سايد عندك الرايت إير. تمام. نذهب إلى الرئيسية. طبعا عندي تيست هيستوري موجود، يظهر لي كل الأطفال اللي تابعين لدي.
So what's next? We are working now to have the norms and validation, regular use every day, and the launching in large scale and receiving the feedback and for preparing for next version. I consider it its achievement, but still it's a small step, hoping to lead to giant leap in this field. Before I finish, I should thank all the team who worked for a couple of years to develop this software, led by Professor Abdurrahman Sanusi and Professor Tamer Musallam, and all the other team from audiology and speech sections departments in King Abdullah Ear Speech Center and the King Abdulaziz University Hospital, and also the IT teams and Mr. Ibrahim Al-Dubayan, who recorded the test, and Medical Company, who supported all this work. Thank you, and that's my email if you would like to contact me about anything.
Okay. Thank you, Dr. Midhat. We won't have time for a question now.
Thank you, Dr. Midhat. Now our next talk will be presented by Dr. Tawfiq Khrezi. He is an otologist and the director of Cochlear Implant Center in Jazan. Dr. Tawfiq will talk about how to establish successful cochlear implant center and utilizing community participation. Welcome, Dr. Tawfiq, please.
Assalamu alaikum. Thank you, Mr. Chairman, for allowing me to present my topic today. Assalamu alaikum, كيف حالكم? Today I will talk about how to establish the successful cochlear implant center and how you are utilizing the community participation, المشاركة المجتمعية. In the beginning, I was showing how the steps in MOH, how to request for approved cochlear implant center. In the beginning, some requirements from MOH. المراكز المتخصصة يعمل طلبات من كل مركز. الطلبات إذا كانت ظاهرة هنا وجود استشاري جراح, surgeon, audiologist, speech, team, coordinator, OR rooms, weekly OR rooms for cochlear implant weekly. And لكم تشوفوا هذا أول مرة ما أدري دكتور أحمد البخير يسمح لي فيها أو لا. And OR rooms weekly, monitoring also, MRI, neuroradiology in the same hospital, sedation, anesthesia for MRI patient or child patient available in the same hospital. After these steps, the next step for request, ask to إدارة المراكز المتخصصة in the same city to mailing for MOH. تكون الزيارة الوزارية تكون متضمنة قائد المراكز المتخصصة في الوزارة لزراعة القوقعة، دكتور غالبا الدكتور أحمد الظفير، الدكتور علي ضامن والفريق اللي معه. تتم الزيارة حساب المعايير هذه التالية. متى ما كانت متوافرة يتم الأبروفد وتحصل على شهادة الاعتماد. شهادة الاعتماد عندنا في وزارة الصحة A and B and C now. A if have 2 surgeon, B if you have only 1 surgeon. بناء على شهادة الاعتماد الوزارية عندنا الاوتكم. مثلا إذا كان عندك جراح واحد كاتيجوري بي يكون معدل السيرجري بير مانث at least 3 cases per month. If you have category B, the surgery will be at least not less than 4 cases. So why it is important to cochlear implant center? That will lead by the end for more organization, less missing for the child, good counseling, peri and post implant, surgery at preferred time and good time for the child. Fitting and programming will be easy for audiologist and for company representative, and also for rehab, monitoring outcome, performance, and etc. So it is teamwork, family and child. It is 2 main story in this sequence. The surgeon, for the CI committee, audiologist, speech language therapist or speech rehab, and family counseling. It is important sequence here in the cochlear implant before the committee, and social service and social worker, and psychiatry in some cases, psychiatrist physician. So more organization, less missing for child, less missing peri-implant, and he will come at the preferred time to good outcome. In this sequence, امشوا معي في السيناريو هذا. child not passing the screening. So what the next step usually? We will proceed for ABR. If not passing the ABR, that means have to present with cochlear implant center in the cochlear implant center. The main defect at this point here. How we can detect this child and how we can present him in the cochlear implant center. أتوقع الدكتور علي المدير talk about this point. So in our experience in Jazan, cochlear implant center in Jazan, we have 2 methods. Most of the center, by the way, it is the same. الدور الأبرز على الكوردينيتور. And في معظم المراكز عندنا في المملكة have Excel sheet تتضمن البايوداتا للمريض، تتضمن الكوردينيتور work up or work flow، تتضمن الأوديولوجيست planning for programming, planning for hearing trial, planning for ABR win, and system in the software or in the medical record. I will show our Excel sheet. احنا من الميزه عندنا في منطقه جازان ان طبيب الاوديولوجيست او فحص السمع سكريننج in the same hospital and he's working with my team الدكتورة إيمان. So the audiologist here in my center, she will present the date of the first date this child present in his in his clinic. نصبح احنا محاسبين في المركز على التاريخ هذا، التاريخ اللي عملت له ABR ونت باص. احنا عندنا معيارنا في مركز القوقعة في منطقة جيزان should be بعد التاريخ هذا ياخذ له تقريبا 3 إلى 6 أشهر هيرنج ترايل. بعد الهيرنج ترايل بعد 3 إلى 6 أشهر هذه لازم خلال 3 أشهر نكون زارعين له بقرار واضح بإرجكشن أو رفض للزراعة. فهنا دور الأوديولوجيست، هنا دورنا احنا الجراحين، تدخل التشخيص، تدخل التشخيص وتدخل بعض الطلبات الخاصة للمريض. Here the coordinator. He will request the CT and the MRI. He will follow the CT date, the MRI date, if the child needs sedation, need anesthesia or no. Here our audiologist, he will make his finding. Also, the speech assessment will share with us. He's shared with us in this Excel sheet. Same. تعالوا نلاحظ هنا some noted. هنا تم إبلاغ الأسرة، تم إبلاغ الزوج وطرح الحلول، تم إبلاغ الزوج. هذه الحقيقة تساعدنا احنا الجراحين إن احنا نعرف لأي مرحلة وصلنا ما قبل اللجنة. مثلا في بعض هنا الأم موافقة، الأب رافض، الأم منفصل، الأب رافض. حتى أنا كجراح يهمني أعرف هذا الشيء قبل اللجنة. هل أحتاج أكلم السوشيال ووركر ولا لا؟ هل أحتاج أجلس أنا مع الأسرة مع السوشيال ووركر أو لا، كقائد مركز وليس كجراح. After that, here our conclusion. We are تقريبا معظم المراكز عندهم same form of the committee. أحد من الشباب عنده نفس الفورم هذا MOH Center. شباب باقي المناطق أي مركز أي شكل تستخدمون أي for CI committee. طبعا هذا مستنسخ، يمكن الدكتور شذا عرفته، احنا مستنسخينه من الجامعي. عملنا فيه some modification بناء على المركز عندنا. هنا دور المنسق حق المركز يعمل conclusion of the committee, approved, rejection, postponed, and such like that. By the way, also post implant, we have Excel sheet to follow the child. Fitting when, first programming when, send it to the speech when, first post-op speech clinic when, and progressing of the child in the speech. وأنا في البيت أتابع المريض هذا. لا تحتاج أفتح السيستم السوفت وير حق المستشفى ولا لا. طيب بعدين انتقلنا للمرحلة الثانية، جتنا الشراكة المجتمعية. الشراكة المجتمعية كان في اتفاقية بين وزارة الصحة تقريبا قبل 4 سنوات مع شركة الهنوف لتشغيل 3 مراكز زراعة القوقعة، تهيئتها هيكليا إنشائيا مع قوة بشرية. كانت في عهد معالي الوزير توفيق الربيعة سمية حضور الدكتور التويجري تقريبا قبل 4 سنوات. كانت تتضمن سبيش ريهاب، سبيش لانجوز، قوة بشرية مان باور في جيزان، تبوك and القصيم. نوريكم our experience in جيزان. هنا كانت المرحلة الإنشائية reconstruction phase for speech and audio في غرف العزل الصوتي. هذه النتيجة النهائية. طبعا يشكرون شركة الهنوف على هذه المشاركة المجتمعية. هنا السبيش دكتورة شهد العطار، الحقيقة محظوظين احنا فيها منطقة جيزان. ايش القيمة المضافة في موضوع الشراكة المجتمعية كان عندنا في منطقة جيزان؟ more OBD for post-op, more counseling pre-committee, more speech rehab season, rapid improvement in performance, early detection for some child regressing or missing, so that more organization, less missing, good counseling, surgery pre-firm time, rehab, good, monitor well, and performance excellent. This one my center and my team. Thank you all.
Thank you, Dr. Tawfiq. I just would like to share our experience in terms of collecting the data in the Excel sheet. We used to use similar as what you are doing, maybe in 2000, when we started 2015 in King Saud Medical City. 2019, we proposed to have our own CI registry, and we copied that from the trauma registry in our medical city. And 2020, it was approved by the CEO. So all of this is in the registry, including the committee decision, the coordinator input, and all, of course, the team. And it worked really well, and it will be a resource also for research, for finding data, which I think it would be like, I hope it will be like a model to be followed. And also, it's better if we have it like integrated in all the centers. So if the patient implanted one side in our center, the second side in yours, so we'll have the same information about the patient.
Actually, it is this point was discussed yesterday between the center coordinator. I think each one has shared his experience in the Excel sheet, how he's managed. I think it is the first step for patient implantable child registry in the country. ممكن أنت تعرف من الإكسل شيت هذا عندنا في البنك هذا المريض زارع، المريض متى عنده موعده في جيزان، متى عنده مثلا زارع في الجامعي أو زارع مثلا في الرياض، يصير يعرف متى موعده في جيزان، هو هيز ميسنج نوت ميسنج، هو ليش جاء طلب الخدمة عندي في الرياض، واي هو تم صرف له بروجرامينج هناك، صرف السماعة له هناك أو لا. وهذا الزملاء في الأم اتش running on that.
And also we're still using this
Yes.
even for follow-up post-operative.
Exactly.
So
yeah.
we follow the patient, what he's doing in terms of AVT rehab or audiology outcomes. If you decide to do the second side, you go back for his performance, and then it will make it easier for the committee to make the decision as well.
Exactly. By the way, أنا حاولت أتكلم في المحاضرة بالعربي because some coordinator is not speak English. كثير الحقيقة نسبة كبيرة من الكوردينيتور غير متحدثين باللغة الإنجليزية، فكان يعانون بالأمس، حاولنا نعملها بالعربي. حياكم الله.
Okay, الله يعطيك العافية. Actually, another small comment regarding what Sahar was saying. يعني أتذكر لما إحنا حاولنا نسوي حاجة زي كذا في التخصصي برضو، فكان عندنا حتى إحنا we involved the geneticist at that time. فهو بس أتوقع امتدادا اللي انتوا اللي قلتوه، لازم يكون فعلا في شيء موحد. زي في بريطانيا كان عندهم الداتابيس، يعني انا كنت اطلعت عليه، فالداتابيس حتى includes يشمل حتى عشان خاطر اتكلم عربي، يشمل معلومات حتى عن المدرسة، فهو لازم يكون كل شيء مربوط مع بعضه. يعني حتى معلومات عن المدرسة، تطوره في المدرسة كان برضو مشمول، يعني مو بس ناحيتنا احنا متابعاتنا. اتوقع هذا الداتابيس هيكون مره مفيد اذا قدرنا فعلا نوحده. Okay, thanks.
Now our second talk will be with Ms. Dalal Rushidan. She will talk about the Arabic matrix test. Dalal is a senior radiologist, clinical technical specialist and in charge of research cochlear in Kingdom Saudi Arabia. Please welcome Dalal Rushidan.
Thank you so much, Sahar. Thank you so much, Dr. Shada. Thank you, everyone, for inviting me today to have a talk about the Arabic matrix test. If you can upload my presentation, please. Yeah, thank you, everyone. I would like to introduce myself. My name is Dalal Rushidan. I'm a senior radiologist, and I'm a clinical technical specialist at Cochlear, and I'm in charge for research in Saudi Arabia. So today I would like to talk about Arabic speech matrix test. The outline of today will be speech perception test and speech and noise. Then I'm going to talk about Arabic matrix test, the test setup, test, retest reliability of Arabic matrix test, and then what is next. So, speech perception test and speech and noise. So, the rationale of using speech perception testing is to estimate the person's communication function in the case of non-typical hearing level, and that's coming from the principle of speech perception. As we all know that pure tone audiometry is not sufficient to predict the communication function for individuals. And if you use sentence as speech perception material, that's going to be even closer to the live situation. And if we add noise as a background for this sentence, it's going to be even closer to a person, going to be like as realistic environment for everyone in a daily life. So since speech audiometry has been developed and it's implemented in audiology and as an assessment for audiology, So in 1996, it has been used aided articulation index evaluation to evaluate hearing aid fitting for hearing impaired children. And in 2015, the speech audiometry has been a predictor for CI candidacy. And lately in 2019, perceived quality of speech and noise is considered as a predictor of performance. So if a speech audiometry in a quiet is very important, speech and noise is even more important, because as we all know, the patient coming again and again to our clinic, usually they are not complaining about listening in a quiet environment, because they said, in a quiet we are doing fine, but in noisy environment or if we are in a group, usually this is their main complaint. So, and from normal hearing, we all maybe perform the same in a quiet, but in noisy environment, we vary differently. So this is show the importance of speech testing and show also the importance of speech and noise testing, especially that's gonna be like a realistic environment for every day. So if we would like to implement speech testing and we would like to put a background noise on behind it, what kind of noise we would like to put? We have different kind of noises. We have pink noise, white noise, speech spectrum noise, babbling noise, and so on. So this is one of the study that's testing the different type of noises and have different effect on speech recognition. And they have found that speech babbling is the most difficult one in terms of different kind of noises. And we should consider that when we are putting noises as a background, when we would like to test the speech and noise for the participant, that the speech babbling is the most difficult one. So from what we have talked so far, that speech communication is the most important aspect of hearing. We need to have a correlation with the audiogram. We need to have a high precision. And speech audiometry in noise, this is what reflects everyday situation. So let's talk now about the speech matrix test. Speech matrix test, it's a pre-recorded speech testing and it resembles everyday situation, which means that the person would listen to complete sentences in noise with the measurable tools. So the matrix sentence test, it has 5 different words and it's semantically corrected and it's unpredictable. And there is a background noise that's going on when the person is listening to these sentences. This is a kind of a material from English matrix test, and later I'm going to talk about our Arabic version. So why speech matrix test is important? It has different features. It's a fully automatic test with adaptive speech and noise, which means that when the patient performs well, the speech noise ratio is going to drop down. And when the patient has a difficulty to listen to the sentence in a background noise, the speech and noise ratio is going to grow up. And it has a very small precision with a high range, with a range of plus or minus 1 dB. It has a meaningful structure, which means, as an example in Arabic, we have name, verb, number, noun, and adjective. And it creates seemingly random sentence from an inventory matrix. This is highly important because our cases that's coming to our clinic, they are coming again and again. And if we are testing with the same list again and again, at the end of the day, they will memorize this sentence. So this is really important to have a matrix when we have a speech test, because with the matrix that we have up to 100,000 sentences. Can you imagine that? So the patient, even if they come again and again, they will have really difficulty to memorize this sentence. So the reliability for these tests is very high. And the most important thing, that speech matrix test is suitable for any person who aged 13 and above and had appropriate language development and normal cognitive ability. So internationally, we have a matrix test in 10 different languages, and now we have Arabic version as well. The aim of matrix test to have a multilingual speech audiometry within the same country, which gives the ability to compare the speech audiometry across countries and with different languages. And that will give us an opportunity to have a multi-central studies, because we are using the same test with a pre-recorded version. I try to find literature about what we have so far in different languages, And I found this is the mean of signal-to-noise ratio at 50% for different languages. As an example, for Danish, it's -8, Mandarin is -10, Italian is -8, Russian is -9, Australian is -10. So let's talk now about Arabic speech matrix test. It has been developed by Heretic Company, and as we all know that Arabic has different features and different characteristics, so they have make sure that it's a number match, feminine and masculine match. And the structure for each sentence is going to be verb, noun, number, noun, and adjective. So, as I explained before, it has up to 100,000 possible sentences, so it's really difficult to memorize this sentence. And it has a natural sounding sentence, unlimited repeatability, it uses an everyday life, and with a complete sentence and a background noise. These are the kind of different sentences that can be produced by the matrix test, and I'm gonna play a sound so you would see like what is the test itself.
أخرج نبيل 7 كراس ثمينة.
So this is an example of one sentence that's going to be produced and listened by the listener. Arabic matrix test has been done through optimization with 19 normal hearing subjects, and they determine the speech recognition threshold of each word. They adapt the level of each word to fit the other word. So after optimization, if you can see this picture, after optimization, it's in the gray color, and before optimization is in black color. You see after optimization, it's becoming shorter in terms of distribution and more precise. And that gives the test become more homogeneous, and the result is high in precision of measurements. So let's see now about the test setup. Here you can see in the picture that the person who would like to be tested is surrounded by different speakers, and the audiologist will be in front of the screen to produce the test for the participants. So before the test, we should instruct the patient and tell them what will happen and what is to do. It's recommended by the company to do 2 training lists before the first time of doing the test. One of them is at constant level, the second one is adaptive level. And here is another screen where you put the different parameters for the test. So you will put like, is it 50% of threshold, 80% of threshold, 20% of threshold? You would decide which side the speech coming from, and which side is the noise is coming from, and if the speech level is fixed, what's the level of the speech in terms of dB, and so on. And what is the list that you want to introduce to this patient for today. So during the test, the audiologist would see something like this. So which means that this sentence is presented or played to the listener. And after the patient responds to this sentence, you have to score by word, not by sentence. Which means if the patient is score 3 words out of 5, you have to press the 3 words precisely. And the test by itself, it's going to drop down the speech in noise ratio or to increase it based on the patient responses. So I think I have covered already most of the part about the Arabic matrix test. Let's talk now about what we have done so far. With King Abdullah Ear Specialist Center, we did a study that related to retest reliability of Arabic matrix test. So our aim is to study the reliability for the test, and we have been done for 75 participants. 31 for them were normal hearing, and 44 with hearing devices. With different hearing devices, we include cochlear implant candidates, cochlear implant users, and different hearing devices users like hearing aid, BAHA, middle ear implant, and so on. And all listeners were trained for the test, and the test is done by 2 steps. The first one is speech from front and the noise from the right. The second one is speech from the front and the noise from the left. We repeat each of these tests twice to measure the reliability. In terms of enrollment participant that we had for this study, it's a varied between different groups, which is normal hearing, cochlear implant recipient, and other hearing devices. We have a combination between male and female, and the age group is from 13 to 70 years. We try to make as distribution as possible so we can cover all the ages. So in terms of result, we have found for normal hearing, in average we have -11, and for CI is 14.2, and for other hearing devices is 5.5. If you can see the distribution for cochlear implant, you would see like it's from -11 to 43, and this is surprising for me at the beginning, because if the cochlear implant had received a very good rehabilitation, they might get as good as normal hearing, which is -11. And we have a quite large distribution, because we all know that there are different factors that impact the development of language and their ability to listen in a noisy environment. So when I compare the matrix test with different languages, we see like we are quite better, but not significantly better, like compared to other languages. In terms of reliability for the test, we have found that the reliability for speech testing, it's varied between good to excellent reliability. So what is next? We've already done the simplified Arabic matrix test. It's still like we finished the data collection from multi-center study, and I think they will analyze the data, and then at the end of this, we hope that we will have the simplified version for Arabic matrix test that's suitable for pediatric population, and we hope that we have pediatric Arabic matrix test on the clinic, and I think this is a potential participation in a multi-center studies research across countries. So these are my references, and thank you for listening.
Thank you, Dalal, for your presentation. You are on time. Any question for Dalal? Okay, so we will move to the last talk in this session with Dr. Ibrahim Shami, otologist and CI surgeon in King Fahd Medical City in Riyadh. Dr. Ibrahim will talk about ABI candidacy and Saudi Arabia achievement. Please welcome Dr. Ibrahim.
Thank you. Thank you. And this is maybe the last lecture, and will be it is different from cochlear implant. The second step after cochlear implant, if there is no benefit from cochlear implant or difficult to do it. In cases, the cochlear implant will give results with sensory neural hearing loss with good outcome. But if the implant cannot be done for the reasons we'll discuss later, then the second option is auditory brain implant for the second neuron orders. The history behind that started by Volta. He's an Italian scientist, inventor of the battery. He applied the sound in his ear canals, and he heard bubbles in 18th century. And then followed by, there is no working. It's working here, but not then. Hello, please. Yes. The first one who stimulate the cochlea is Golem. He's a neurologist from French, and then in 1883, and then followed by in 1957, by Giorno, who's the one stimulate the cochlea itself, the cochlear nerve with good results. And then the William House who implant the first cochlear implant with single ball. From that time, after around 18 years, the ABI started. The first ABI also, it is a single electrode after NF2 removal by William House again. The timeline for development of the ABI is from 79 till 91, it is single channel with implanted 25 patients of NF2. At that time, the only patients NF2 cases. Developed from single ball to 2 blades and then 3 blades till 92. 92 then we got 2 variants, the European variant, which is multi-channel 21 electrodes, and American or North American, which is 8 electrodes in early 92, but improved with European, and this is the last one from that time, from 92. And then minimal improvement till 2014 with MRI compatible ABI. The indications, we have 2 indications: bilingual with patients with absent cochlea or absent nerve, or hypoplastic nerve with no improvement with cochlear implants. If there is hypoplastic nerve, if there is absent nerve, then ABI. Postlingual, usually the classical one is NF2 patients, the only one approved with FDA. The pediatric patients not approved with FDA, approved with the CE market. The other one is meningitis, temporal bone fracture with avulsion of the cochlear nerve, advanced otosclerosis with problem with the facial nerve stimulation, and there is no discrimination with cochlear implant. And other patients with unsuitable for cochlear implants like tumors. But with all indications need reasonable expectation of the patients. If there is no good expectation, the expectation very low, not like cochlear implants, then the patient will implant it. ABI in children is still not approved with FDA. It is approved with the CE market, and most of the cases implanted in Europe and Asia. They didn't approve because there is a risk of anesthesia in children. The intracranial surgeries in America, elective cases, not agreed for if the patient is less than 1 year. There is also a problem with the electrode movement in pediatrics with the edema of the brain, and syndromic patients sometimes with difficult anatomies and tonotopical arrangement, because if absent cochlea, maybe there is absent of the cochlear nucleus, and difficult pre-op to assess if there is cochlear nucleus or not by audiology. And MRI is not easy to detect. Also the rehabilitation of the patients, of the pediatric patients. The surgery, either we have retrosigmoid, and this is the axis of neurosurgery. If there is no tumor, it is better retrosigmoid even for us. Preservation of the cochlea, if there is suspicion of the nerve, faster, 15 minutes. The translab, more than 5 hours just for drilling. Stabilization of the implant, closure of the dura very well, less contamination, but there is cerebellar retraction, very extensive retraction, and maybe cause of the edema. Translabyrinthine is good for NF2 patients. better view, but there is infection if it is infected mastoid. With all procedures, both procedures, then we'll follow the facial nerve and cochlear nerve together with the glossopharyngeal nerve. And then folliculus should be retracted, and then foramina flushka will follow the foramina flushka. This is the foramina flushka, just some anatomy here. This is the one with folliculus there, can be seen on, yes. And choroid plexus retracted, and then we'll implant in the foramina flushka. Monitoring will monitor the ABR, electrical ABR of the implant, because there is no ABR. And will also monitor the other nerves, especially the lower cranial nerves, because there is cross-stimulation to other nerves and nuclei. Complications, craniotomy complications, cerebral retraction, bleeding, cranial nerve deficit, cystic leak, hydrocephalus, migration of the array, auditory failure, stimulation of the failure, and non-auditory stimulation. This is the most important one. And in cases of not complete removal, will not put it. If maybe the other problem is maybe the recurrence of the disease, and difficult to control by MRI in these cases, not easy. The surgery is as follows. This is retrosigmoid approach with elevation of the precondylium, and then briosteum, and then after opening the dura, we'll follow the nerves and with glossopharyngeal and facial nerve, and then the cochlear nucleus just beside the glossopharyngeal nerve. We have in Saudi Arabia 2 companies, Cochlear and Medel, with different electrodes. This is for Cochlear with 21, and Medel for with 12 electrodes. Achievement in Saudi Arabia. King Saud University started in 2011, and till now around 10 cases done, 1 NF2 and the other 10 pediatric patients with a good success rate. They have it. Maybe Dr. Methat, he's following the patients, and they're in KFMC. Started last year with the tumor. We have NF2 cases, a lot of NF2. Then we have to decide to start the ABI in our center. Especially we have 25 cochlear implant centers. In Ministry of Health, there is no single one doing, if there is any anomalies, nobody will do it. Then we decide to start with NF2 patients, and then she has good results. And then we'll start with pediatric later on. And this is the beginning. And we start with collaboration with neurosurgery, Dr. Mohammed Bouhaqi and Dr. Agada from audiology, initiating the program, and it is in process, our program. Inshallah, we'll succeed to do it. And this is the first surgery with the tumor removal. It is facial schwannoma, NF2 with facial. Then we preserve the cochlear nerve during surgery. So cochlear implant trial done, but there is no response, so we shifted to ABI. Any questions? Thank you very much.
Thank you, Doctor. Any question for Dr. Ibrahim or for any previous talker?
The whole country, 1 center is enough in our country. Especially the tumors, we don't know, but I have around 5 cases now waiting in NF2. Neurosurgery, they have more than me. And pediatrics, one center is enough. 25 centers we have. If there is one absent cochlea or meningitis case with labyrinthitis, ossification of the cochlea, this is rare. Maybe in each year we'll get one or two patients.
Thank you, Dr. Ibrahim. Thank you all for attending this. You have a question? Okay, there is one question, Doctor.
Is not with me.
Okay. By that, we reach the end of this session, and we'll have a coffee break now for 10 minutes. وللتذكير التسجيل الحضور اليوم الثاني اللي ما سجل بالمدخل. شكراً.
معرفش البريك المفروض 10 minutes، نديهم كمان 5 minutes. تدينا إشارة البدء، منتظرين إشارة البدء منك انت. السلام عليكم. Assalamu alaikum. We'll start the second session, please. Welcome again, everybody. We'll start the second session. It will include 3 presentations and will be the questions after all the 3 presentations. For the first presentation, it's my pleasure to introduce Dr. Ala Al-Shahri. She is a speech therapist working in King Fahad Medical City, has her master's degree in speech difficulties 2017. She's a member in the CI Scientific Committee. Around 10 years of experience in dealing with children and adults with hearing loss and with CI recipients, adults and pediatrics. She will present about a very interesting topic, adult oral rehabilitation. Please welcome Dr. Ala Al-Shahri.
Okay, hello everyone. So today I will be, closed, sorry. Closed. مسكر. Sorry. So today I will be talking about adult oral rehabilitation. So when we say oral rehabilitation, many of us think about pediatric population and children. So just to start, I would like to talk about the difference between oral habilitation and oral rehabilitation. So in oral rehabilitation, our main target is children who are either prelingual or perilingual. And the main goal is to develop auditory and listening skills that are non-existent. In oral rehabilitation, on the other hand, we are thinking about adults and teens who are postlingual. And the main goal would be to provide them with tools to help them regain the skills that they lost due to the hearing impairment. So we never question the importance of oral habilitation. We all understand the need for our oral habilitative services for children. However, when it comes to adult rehabilitation, there are a lot of programs that do not require or do not stress the importance of auditory training tasks and oral rehabilitation post-CI to the patients. So we are still in the progress of developing and in making oral rehabilitation programs across all of the centers. I know a lot of centers that do not require it or do not talk about it to their patients. And when we think about the patient's needs, the main goal is to empower them and to improve their quality of life. So we need to think about having mandatory oral rehabilitation programs for them. So the definition of oral rehabilitation, it is an intervention that is aimed mainly at minimizing and alleviating the communication difficulties associated with hearing loss, with the main goal, of course, to improve the quality of life. There are 4 main components of oral rehabilitation. So first of all, we have sensory management, which is usually done by the audiologist and by the ENT, and this targets auditory function. And then we have instruction, so instruction on how to use the listening devices and how to create listening environments. And then we have perceptual training. So this will target auditory, perceptual, and sensory tasks. And lastly is counseling, which is done by the whole team, the whole oral rehabilitation team. And SLPs have a major role in. Okay, so the population of hearing loss is a very heterogeneous population. There are different reasons and different types of hearing loss. So there are several factors that we need to consider that might affect the outcomes. We need to ask about it during our assessments, and we need to discuss it with the patients before their cochlear implantation. So first of all, the hearing loss, the type of hearing loss, the onset of hearing loss, the duration of hearing loss. That is all very important for us to understand, and it will predict the outcomes of CI. So people with shorter duration, for example, will have better outcomes than people who have had longer durations of deafness. The next thing is neural population reserve. So we know that auditory deprivation does affect the neural activities in the brain. So the longer the period, the harder it would be to get expected outcomes. So this just needs to be discussed with the patients before the cochlear implants, so their expectations are clear for them. And then we have the cognitive state of the patient. The current mode of communication, and lastly, the patient's motivation to engage in these tasks. Okay, so one of the things that I always like to explain to my patients during the first session, pre-CI, is that it takes time. We need to be patient. We need time for the brain to adapt to the new listening way for it. We need time with auditory training tasks. We need enough motivation. We also need continuous programming, especially during the first year of the implant, for us to reach the best program for the CI user. So all of these will contribute to better CI outcomes. Okay, so as SLPs, we have two main, from the components, we have two main things that we're focusing on: perceptual training and counseling. For today, I'll just focus on perceptual training. We have auditory training, and we have communication and conversation therapy. So what is the theory of auditory training? The physiological theory underpinning auditory training and how it works is that improved or increased auditory training will lead to eventually increased neural pathways in the brain that will help in improving the CI outcomes. There is a lot of evidence in support of early rehabilitation. So the main goal for us is to provide evidence-based practice. Unfortunately, going into the research, there isn't something that says oral rehabilitation works in itself, because oral rehabilitation has many different areas, and a lot of these studies are targeting areas within the oral rehabilitation. One of the two that I found, the systematic reviews that I found, were one done in 2005. This one stressed the importance of synthetic training and said that it's more effective. Synthetic training means that they're focusing on meaning and sentences rather than structured tasks in sounds. Opposed to that, one done recently in 2022 said that analytic training approaches are more effective with training for better outcomes. So analytic training means that we're focusing on sounds and then progressing onto sentences. They also found that nonsense word training improved sentence recognition in noise by an average of 10 to 15%, and that these improvements were maintained across 26 weeks. Okay. There was another study in 2012 that studied speech tracking. Yeah, that studied speech tracking, and they reported that it helped in sentence recognition from 15 to 20%. And then there were 2 studies that reported that we can improve music appreciation and use of telephone if they are targeted directly in our sessions as well. So these are all promising results about the importance of auditory training and early rehabilitation. But yeah, they're all targeting different areas and searching different areas within early rehabilitation. Okay. So the next thing that I'd like to talk about is the hierarchy of auditory training. So Erber in the 80s developed this main hierarchy of training. So we have first detection. Is there a sound or is there not a sound? Discrimination, are these 2 sounds that I'm hearing different or are they the same? Identification and recognition have been integrated, and they both mean, can I identify the voice that I'm hearing, or can I identify the word that I'm hearing? Lastly, it's comprehension, and that's comprehending what I'm hearing and understanding what I'm hearing, and meaning, developing understanding for meaning. The types of auditory training, we talked a bit about it in the evidence, the analytic and the synthetic. So analytic, it goes from the bottom up. So we're gonna start with sounds, we're gonna go to words and then sentences, and then lastly to conversation and meaning. In the synthetic, top to bottom, we're gonna go from conversation and meaning, then sentences, then words, and then lastly sounds. So it's 2 different approaches. There's evidence supporting both of them. What I found was, and what I found some articles were supporting, is the use of a combination of both analytic and synthetic. We don't have to use just one approach. So I created a sample goal for a patient, a short-term sample plan during the first 2 months, let's say, of post-cochlear implantation. So as you can see, we don't have to just target detection or identification or comprehension. We can do them all in unison in the same time. So for detection, we're working on detecting environmental sounds, new environmental sounds, detecting link sounds, which we all work on. For discrimination, we could be working on discriminating between voices. So I had patients who wanted to discriminate between the voices of his daughters, and that could be worked on early on, because it's happening every day in his life. So I can't say, no, we're in a detection phase, let's stay in don't go to discrimination. Discrimination between speech sounds. For identification, identifying familiar voices of listener partners at home, identifying link sounds if it's possible, which is possible in the first sessions, and identifying familiar words. For comprehension, we could work on answering questions, simple questions, at least in the beginning, and routine questions, and engaging in conversation. Okay, so when we're preparing for an auditory training session, how can we need to think about how we can make these tasks a bit easier so that the patient isn't frustrated, and we need to know when we need to challenge them if the goal is too easy for them. So I really like this picture that was talking about how we can make it easier or harder, and I always apply it in the session. So if we can make it easier by making it a closed set, so I'm going to tell you a number from 1 to 10, and you're going to identify that, versus a more open set. I'm just going to tell you a number randomly, so you need to identify that. The stimulus unit, words are usually easier than complete sentences. Is the stimulus too similar? So, or is it, we can make it easier to make it more dissimilar and make it harder by making it more similar. Context, are we talking, if it's very high, so maybe we're talking about a specific picture or a specific topic, so we have context and it's easier to understand, versus low context. Structured tasks are also easier than spontaneous tasks, and a quiet environment is usually easier than a noisy environment. So this is an example. If our goal for this patient is identification between minimal pairs, so words differing in one sound that are both nasal, ma and na. So the goal is for him to identify, not just discriminate. Discriminate would be same and different, but we're asking him to tell us which word that he's hearing. So nal versus mal. If it's too easy for the patient, then I need to make it a bit more challenging. So we could use nonsense words, words that have no meaning and have no context. We could do the same goal, but in noise. We could have it in the final word position, which is usually harder and more challenging for the CI user to hear. If we want to step it down a bit, because it's too hard, we can make it a discrimination task. So we'll ask him, can you tell us if it's same or different? We can also, if it's very hard for the patient, and ma and na are very similar, we could make it a bit easier, and we'll use a nasal and an oral sound, so na versus la, or ma versus la. Okay. The next task is identifying words presented verbally. So this is a task that we can target with our CI user. So if we want to make it a bit harder and a bit more challenging, we can make it an open set. We can even use less common words. So there are familiar words that we usually hear every day in our lives, like our name, jawal, matbakh, all of these words. So we're going to use words that we don't hear that often. Or we can make it in a sentence and have him identify the last word or the first word heard. To step it down, we can just say, I'm going to tell you 5 words. Within these 5 written words, I'm going to tell you 1 word that you need to identify. So this is much easier for the patient. Okay. The next thing that I wanted to talk about is communication and conversation therapy. So everyday conversation is the most common site of activity and limitation that our CI users are reporting, and it majorly affects quality of life. So spoken language is a sensory and perceptual task that is mediated by linguistic codes and structures, and it is ultimately a social activity that we all need to engage in. What can we do in conversation therapy? We can use some simulated conversations. So we'll engage the patient in different types of conversations, different genres of conversations, depending, and it can be individualized to the patient's needs. So if they are going into a job interview, we can sort of simulate that conversation. Going to a supermarket, for example, going to a medical appointment, all of these things. So with our patients we would usually say, okay, go and ask for your appointment for the reception area, and we can simulate that conversation before they go and ask for it. The second thing is discuss communication breakdown strategies. So what do I do if there's a breakdown in conversation with another speaker? How can I repair it? Sometimes it would be asking someone to repeat themselves. It could be trying to understand from the context and letting it go sometimes, not always trying to understand everything that is being said. Lastly, self-advocacy. So I think this is the most important one. A lot of our CI users do not self-advocate for themselves. So I had one of my patients who said that her sisters and her family members would talk to her when she's in the car. They jump in a conversation with her, and if she doesn't understand what she's saying, they'd take her out of the conversation and say, why don't you understand us? You're wearing your CI. So she was upset about it, and we talked about how listening in the car is actually challenging for all of us. And you need to tell them that. We can talk about, for them, they need to say your name before engaging in conversation, so they grab your attention first. And you need to tell them how it made you feel these last couple of times that it happens. And she did it, and she was very satisfied with the results. So, lastly, one of my patients his name is Abdul Aziz Al-Asmari, he's an English teacher. He was very happy with his CI, and he was happy to participate in the conference and present his experience. So I'll leave you with his short video.
السلام عليكم ورحمة الله. عبد العزيز الرسمري، معلم لغة إنجليزية، 43 سنة.
I don't think the sound is.
السلام عليكم ورحمة الله. عبد العزيز الرسمري، معلم لغة إنجليزية.
It's not clear. Is the sound clear? No.
43 سنة، مزارع قوقعة.
الفيديو هذا مهم؟ فيديو مهم؟ صوته في صوت.
Okay, apologies for the technical issues. It's going to work in a minute.
السلام عليكم. السلام عليكم ورحمة الله. عبد العزيز الرسمري، معلم لغة إنجليزية، 43 سنة، وزارع قوقعة في الجهتين ولله الحمد. حاب أني أقدم لكم تجربتي وأوضح لكم أهمية التأهيل للكبار، الزارعين الكبار. ولكن قبلها كنت سمع طبيعي وسماعة التقليدية العادية الطبية، وبعد كذا زرعت. مقارنة كجودة صوت أو إيش الأقرب والأفضل، طبعا زراعة القوقعة هي الأفضل والأقرب، بل إنها مثل السمع الطبيعي. السماعة التقليدية كانت فقط تكبير صوت. بخصوص التأهيل فعلا كان جدا مهم بالنسبة لي، ويا ربي لك الحمد، اجتهدت ولقيت النتيجة الحمد لله. قبل أو بعد ما تقرر لي الزراعة، طبعا سبب فقد السمع هو بسبب حمى ملطية، كان عندي فكرة أنه لا، أنا كبير وعندي لغة وممكن ما أحتاج تأهيل بس أزرع وخلاص. ولكن بعد الزراعة لا، اكتشفت أنه فعلا في صعوبات أواجهها. بفضل الله ضمن البرنامج حقي حق الزراعة أنه في تأهيل تخاطب، ولله الحمد كان مع دكتورتي الفاضلة آلاء، وبدينا برسم جدول معين تدريبات. فعلا كان في صعوبة في البداية، كنت ألخبط، والحمد لله يعني الخطة اللي أعطتني إياها أمشي عليها، كنت أطبقها يوميا وأنا لازم أتدرب. زوجتي ولله الحمد كانت كل يوم معي، حصة مخصصة أني أتدرب. أضف إلى ذلك أنا كنت أسمع عربي أو إنجليزي بحكم أنه عندي لغة، والتأهيل كان من الجهتين العربي والإنجليزي. فالحمد لله يعني بعد فترة بديت ألاحظ أنه لا والله أنا الآن تجاوزت كل المشاكل اللي كنت أواجهها في بداية زراعتي، تغلبت على كثير منها، تحديد اتجاه الأصوات، نبرات الأصوات إلى آخره. ما ودي أفصل فيها كثير، ولكن فعلا كان شيء ضروري ومهم. رسالة اللي وصلها للزارعين الكبار أنه لا تظن أنه إذا زرعت خلاص حتبدأ تسمع وتستمر، لا بالعكس، ضروري أنه تمشي على برنامج يحدد لك أخصائي التخاطب بحيث أنك توصل إلى أفضل نتيجة. وفعلا صادفت وقابلت زارعين كبار لا زال إلى الآن يعاني، مع أنه ممكن زرع في نفس الوقت اللي أنا زرعت فيه أو قبلي ولا زال عنده صعوبة. ولله الحمد يستعجبون مني أني أسمع وأني أشارك، ويا ربي لك الحمد. شكرا على إتاحة الفرصة هذه لي، وآسف على الإطالة. شكرا لدكتورتي الفاضلة آلاء، في حفظ الله.
That's it. Thank you for your time.
Thank you so much. Thank you so much, Dr. Ala. And now with our second presentation.
Our second presentation will be presented by Ms. Muna Bafadl. She's a speech-language pathologist specialized in post-cochlear implant rehabilitation, a member of the American Speech and Language Hearing Association, received her master's degree from Dar al-Hikmah University and in the process of obtaining auditory verbal therapy certification. Ms. Muna is going to present for us a topic about late talkers.
Thank you, Omnia. Good afternoon, everyone. My name is Muna. I will be today presenting about a group of children that we may have all dealt with or worked with during as professionals, as speech-language pathologists or as audiologists or even medical doctors. This group of children is late talkers. Okay, who is a late talker? A late talker refers to a toddler who is between the age of 18 to 30 months, who usually has good receptive language skills and good understanding of language skills, but and typically developing play skills, motor skills, social skills, and thinking skills, while they may have difficulty with expressive language and vocabulary for his age. So, who usually identifies late talkers? Because it's a young age group, they're usually identified by either the parents, the caregivers, and sometimes by the teachers if the child attends in a nursery or in a daycare. So it's usually the parents that usually report if the child has this kind of delay in expressive language. So what are the early symptoms of late talkers? First of all, as an infant, a late talker is usually quiet, babbles less compared to other kids of the same group, and also this child may have a history of ear infections. They also could have limited number of consonant sounds such as ma, ta, da for a child who is 30 months old, which is very limited. And also this child may have limited or no word imitation, which is a red flag for late talkers. These children also have limited vocabulary. What do you mean by a limited vocabulary? Less than 10 words for a child who's aged between 18 to 21 months, or less than 50 words by 20 to 30 months of age. So when we talk about limited vocabulary, we're not just talking, they usually have, like, they might have vocabulary of some nouns, but they don't have the verbs. And also, their vocabulary, they have limitation of even combining these words together to create sentences. So, altogether makes it very difficult for the child to attempt for communications. They have very limited communication attempts. They do not attempt to communicate, and they have difficulty even sharing or expressing themselves, which makes it very stressful for the child. When we talk about the delayed speech language characteristics of these children, they have, for expressive language, they have affected emergent syntax, where they have difficulty combining words together to create two-word sentences such as daddy go or baba rah, compared to thank you. Thank you, it's a two-word that we cannot count as a two-word sentence. Their speech is also affected as in terms of speech perception, how they perceive sound, or even speech processing and understanding of the speech sounds. They also have difficulty, phonological difficulties. They vocalize and babble less, as we said before. They have smaller consonant inventory and simple syllable shapes. So, a lot of researches were done to identify the causes for late talking in children. It's very difficult. However, they highlighted some factors that contribute to late talking in toddlers, which include intellectual disabilities, genetic and family history, and autism, and most importantly, hearing disorders. So let's look closely about how hearing disorders is related to late talkers, since it's the highlight of our conference. Late talkers and hearing disorders have, usually late talkers who were later identified to have hearing disorders have similar characteristics of how they perceive sounds and how they process sounds. They usually have initial and final sound deletions because they have difficulty perceiving some frequencies, such as sa, or sometimes the ta, or the grammatical markers that we use in Arabic for gender markers. They also have sound substitutions. They have voice disorders. They may have difficulty regulating volume or resonance. They may speak very loud or speak very soft and have difficulty regulating their volume. They also have delay in vocabulary, delay in grammar, word order, idiomatic expressions. All of these together makes it very stressing, makes a very stressful environment for the child to express his needs, or even for the family who are waiting for the child to express his first words and to communicate. So this tells us how important it is to start early intervention, beginning with evaluation. Further evaluation, first of all, to rule out any other medical conditions the child may have, such as hearing disorder. The child may need just hearing aids to start with, and then we start the language intervention. And then we go into the intervention, which is usually home-based intervention and family-oriented approach, such as many programs and approaches, such as the Hanan program. We have the routine-based intervention, and we have also the auditory verbal therapy approach. They all focus on approaching the parents rather than the child, because we're talking here about a very young age group. So the parents are very important, and they play a very important role in the process of the intervention. Intervention strategies that we usually focus on with the families, we start by saying to the families, talk to the child. So what kind of talk that we want the parent to share with the child? What kind of words or language? We usually emphasize to use simple language. We speak at the child's level and about something that's present. So it's very important to use the daily activities in our intervention approach, not to have, because we're talking about very young age group, we focus on playtime. Playtime is very significant with this age group, using playtime to emphasize the different words, using acoustic highlighting. For example, while playing with a child, saying, يلا نلعب طيارة، الطيارة حلوة، الطيارة تطير فوق. All of these during playtime will help the child acquire and start to have more communicative attempts during play. And also singing is very important strategy to use with children, because it's easier for them, especially if they have, they're suspected to have hearing problems, to detect the differences in melody. And also using expansion. Whenever the child even tries to produce a sound, we move into a word. If the child says a single word, we try to make a sentence out of it to help the child expand his words and be an effective communicator. And all of this together will help the child to become more confident in communicating with others, because what we try to help the children here is to help them be more confident in their communication so they can have less problems later in life. And to end with, whether a late talking is a stage or a symptom, we always know that late talking, whenever we start early intervention, it's very significant to help these children reduce the impact for them later on in life, and also never to say to the parents or not to address their concern, because parents, when they have a concern, that means there is an issue. So whenever we start the early intervention, we will help reduce and minimize the effects for, in a lifelong of that child. So to end up with, we want all of us to highlight the significance of early intervention for late talking, to help those parents and to improve the quality of life of the child and the family. And here are their references. Thank you.
Thank you, Ms. Muna, for the presentation. It's really nice.
Thank you.
Our next speaker.
Our next speaker is Ms. Noura Naim. She is a senior speech and language pathologist. She graduated from King Saud University. Her bachelor was in audiology and speech language pathology. And she received her master's degree in language sciences with a specialization in language development from UCL in 2019. Noura's clinical experience mainly focused on children with developmental communication disorders, including children who have hearing loss and required AVT. She was one of the founding members of the AAC Multidisciplinary Clinic in King Fahd Medical City, and currently she joined King Saud University as part of their teaching staff. Today, she will talk about auditory verbal therapy for complex communication needs.
Hi, good morning or good afternoon, everyone. Hi. Thank you so much for attending today's lectures. I'm very happy to be able to talk to you. So like Hawazin mentioned, today we're going to talk about AVT for complex communication needs. So we're going to talk about what AVT is, who are the members of the AVT team, some statistics relating to AVT, what is AAC, AAC and AVT, do they work together or do they contradict each other? And I'm going to show you a case example at the end. So what is AVT? So AVT is an early intervention program, and in its basic form, AVT is using audition as the primary source for verbal production. I would like you to bear with me for a second because I'm going to briefly explain the principles of AVT because they're quite important for our discussion later on. So we have 10 principles of AVT. The first one is to promote early diagnosis. The second one is to recommend immediate assessment and a provision of appropriate hearing aids. The third one is to guide and coach parents into using audition as the primary source without lip reading and sign language. The fourth is to guide and coach parents to becoming the primary facilitators for the child's listening and spoken language. And the fifth is to guide and coach parents to creating an environment, a listening environment. The sixth is to guide and coach parents to help integrate listening and spoken language into all aspects of life. The seventh is to guide and coach parents using natural development of speech, language, cognition, and communication. The eighth is to guide and coach parents to help their child self-monitor. The ninth is to administer formal and informal diagnostics, and the 10th is to promote integration of kids with hearing impairment into regular schools. You'd note that I said the words guide and coach parents quite a lot. Of the 10 principles of AVT, 6 of them are guide and coach parents, which is heavily important. Okay, so does AVT work? When we look at AVT literature, we find that both longitudinal, cross-sectional, retrospective studies, they both clearly show that auditory verbal therapy works to improve both receptive language, expressive language, and listening skills in kids who are deaf and hard of hearing. It works best with kids who are identified as having hearing loss before 6 months of age. However, a very important thing to note is that when we look at AVT literature, most literature takes the best of the best. So they take typically developing kids who had early identification, early implantation, and who do not have complex communication needs. Okay, so the traditional AVT team, the main component is the patient, then the caregivers, the SLP, audiologist, and ENT. So some statistics relating to hearing loss in Saudi Arabia. So the prevalence of sensorineural hearing loss in Saudi children is 1.5%, with 36 to 66% being hereditary in nature, and that's assumed to be due to consanguinity. So when we look at the statistics from the Ministry of Statistics, they published their numbers in 2017, their census. It's found that a little bit over 18,000 kids had isolated hearing loss, so they'd have hearing loss without any other medical issues. In the same census, they reported over 74,000 kids having multiple disabilities, including hearing loss, which means that more than double the kids with isolated hearing loss have complex communication needs. So the majority have complex communication needs, not isolated hearing loss. When we look at international numbers, they coincide with the same numbers we have. 23% have intellectual disability, 10% are expected to have cerebral palsy, 7% have autism, and 5% have vision impairment. So let's go back to the traditional team. Does this traditional team cover complex communication needs? I would argue it doesn't. We need to extend the team for kids with complex communication needs. You could extend it to have occupational OT or a PT if you have gross motor or fine motor difficulties. You'd add a behavioral therapist if you have autism, ADHD, any behavioral diagnoses. You'd add a special educator if the child is going into school. You'd add an assistive technologist if the child requires any form of AAC. And you'd add a deaf-blind teacher if the child is deaf and blind, and so on and so forth. So you'd add team members depending on the specific needs of the child. Okay, so what is AAC? You heard me mentioning here that you'd add an assistive technologist, that you'd add an assistive technologist if the patient needs an AAC. So what is AAC? AAC is alternative and augmentative communication, and to be super brief, AAC is anything other than traditional verbal spoken language. AAC could be used to augment, so to support already existing verbal communication, or as an alternative method, so instead of verbal communication. And you could have it unaided. Unaided basically means there is nothing external to the patient. So sign language, gestures, these are unaided AACs, or aided, which vary depending on technology. So it could be very low tech, like a communication board, or super high tech, like brain-computer interfaces. Okay, so you recall that we mentioned the goal of AVT is to have audition as the primary form for verbal spoken language. The goal for AAC, on the other hand, is to increase or improve a person's communication. It has nothing to do with verbal output. It might improve verbal output, which is something we're going to talk about in a minute. Okay, so AAC and AVT, can it work? So you recall we mentioned the principles of AVT. The principles of AVT, 10, 6 of them are guiding coach. I would argue that only one of them, which is the third principle, contradicts the use of AAC, which is guide and coach parents to help their children use hearing as the primary modality without the use of sign language or emphasis on lip reading. So I would argue that this is the only AVT strategy, AVT principle, that contradicts the use of AAC. So do they contradict each other? Let's look at literature and then we can rediscuss this point. So when we look at literature for use of AAC with individuals who have hearing loss and complex communication needs, we found that it improved 81% of teenagers and adults' communication who had hearing loss and complex communication needs, and it improved 90% of children who were deaf and blind. Literature also shows that it improves written communication for kids with hearing loss and intellectual disability, which you recall is the most common comorbidity, as well as literacy for children who are medically free and who only have hearing loss. Moreover, there's a study where they looked at voice output communication aids, and this is the graphic for this study, and they found improvement in speech perception, speech production, and receptive vocabulary. Speech perception is an auditory goal, speech production is a verbal language goal, and receptive vocabulary is a receptive language. So it's improved across the board, which are the same goals as AVT, but they achieved it here with the use of AAC. Okay, so there's one study that I would like to highlight, which is Mazandara's 2021 study. So this was an experimental study where they had two groups. They had an experimental group where they used technology-assisted language intervention, and a control group where they used treatment as usual. So the interesting thing here is that they used AAC as a therapy tool only. It wasn't as an alternative or as an augmentative communication. It was as a tool to train these kids or to teach these kids how to use utterance expansion. They had 3 to 12 years old with mild to profound hearing loss, and they had 24 weeks for this study. So the results were very interesting. So the TALI group, the TALI is the technology-assisted language intervention. The TALI group improved in MLU, which is mean length of utterance, 43%, compared to the 11% of the treatment as usual. They improved in turn-taking, 48%, compared to the 7% of the treatment as usual. And they improved 27% in the use of novel words or new words compared to the 5% of the treatment as usual. So some major strengths of this article, and which is why I wanted to highlight it, is that they did the assessment in a naturalistic speech, via speech sample. So other studies, you might note that they would use the same test before and after, and the issue there is when you do the same test, you can train the child on what the responses you want, and so you'd have skewed data. Here they used speech sample, which means that is the child's speech improving before and after provision of the AAC. They also randomized them into two groups with 4 stratospheres, so they had 2 age groups, 3 to 6, and then 6 to 12, and 2 IQ, nonverbal IQ, below 100 and above 100. The thought process here was because they didn't want to have a group that was stronger than the other group. So if a group had older kids or better IQ, you'd expect the results to be better. So they wanted to randomize for that and control for that. And for this study, they found that children as young as 3 years old were able to complete the therapy, this therapeutic strategy, which means that it is applicable for younger kids. So that's why I quite like this study, because it was a bit of a different way to think about AAC. It doesn't have to be alternative or augmentative. Okay, so do they contradict each other? I would argue that they do not. I believe that we can use AVT principles, but we shouldn't be very rigid about it, because it would be misguided to actually apply the very strict AVT principles on all kids when we know for a fact that they're done with the best performers in mind. We have a lot of kids, more than double the kids have complex communication needs, so we should take what is applicable and then add as needed. So I want to show you a case example of a patient of mine who has a hearing loss as well as is using an AAC. So Mishal is 11 years old. He has intellectual disability. He has cognitive delay, ataxia. He's questionable Joubert syndrome and has bilateral mild sloping to moderate severe mixed hearing loss. He's on hearing aids. He is short-sighted with astigmatism on corrective glasses. So I want to show you first Mishal with low tech, so a communication board, and then I'm going to show you 2 videos with high tech. Let's hope this works. Yalla, bismillah. There is no sound. هو في صوت بس مرة واطي. Can you hear the sound? لا.
صح عليك. شوي على شوي قاعد يحتاج تصحيح.
Can you hear it now? لا.
بطل دور سارة. سارة.
في صوت.
ثاني. مو قاعد يناظر. ثاني. أزرق. Wow.
Okay, so I want to highlight something. So here we're doing utterance expansion. He did 1 word, we expanded it to 2. We're also doing turn taking, we're also doing acoustic highlighting. These are all AVT strategies. But the difference here is there's a communication board in the middle. That's the only difference. So I'm going to show you the second video. This is high tech. I want you to see Mishal continuing in an interaction. صوت مرة واطي.
كلب. ممتاز.
كلب ياكل. لا.
وشو لا؟
دوري.
دورك مرة ثانية؟
دوري.
Okay, دوري. أنا.
Okay, so what did Mishal do here? Mishal asked me to take a turn. And that is part of AVT, but the only difference here is he used the AAC to do it. And you can hear him, he's verbalizing with it because he can talk, but his talk is very unintelligible, so this is quite helpful for him. I'm going to show you one last thing before we summarize. So here, guide and coach parents. You remember, I mentioned 6 strategies of AVT as guide and coach parents, and we're still doing it with AAC, so let's just play this one.
وريني.
نعم.
وريني ايش تبغى؟ تبي موز؟
موزة.
ولا عظم؟
عظم.
فول؟
موزة.
تبي موز؟ اي؟ اوكي.
أبي موزة.
خذ.
عظم.
هونت؟
عظم. أبي عظم.
خذ. ليش قاعدة أزيد؟ عشان أزيد عليها كلمة، يعني هو قال لي عظم فأزيد عليها.
So I'm explaining utterance expansion to the mother, which is an AVT strategy. You can also observe its choices. We're giving choices. We're doing utterance expansion. We're acoustically highlighting. And I'm accepting verbal responses. So he said E. I didn't ask him to pick E in the AAC because it doesn't matter. We're talking here total communication. However, the means of him communicating with me is the means that I want him to do. If the iPod is helping, use the iPod. If you can verbalize, use verbalization. Like the video before, if he can do a gesture, do the gesture. It's all fine. So, to summarize, children who have hearing loss would benefit from auditory verbal therapy. I'm not arguing that they wouldn't. However, AAC could be used as a pure therapeutic tool for both literacy and utterance expansion. But some kids might require AAC as a supportive tool to support verbal communication or as totally alternative if the child is not verbal. That's it. Thank you.
Thank you, Ms. Noura, for your presentation. Now it's time for questions. We will start with Ms. Ala, the first presentation. So any questions to Ms. Ala? Okay, any questions for Ms. Muna for the presentation about late talkers? No questions? Okay, any questions for Ms. Noura? You have? Yes.
I have a question, actually. You were saying, Noura, about auditory verbal therapy and and how it's not conflicting using augmentative communication with auditory verbal therapy. Would you explain more about that? Because actually, I wouldn't say that they will not, they're not contraindicators, but you're not actually using auditory verbal therapy in its essence. It does not go wrong, mention the principles, and it's only one thing that you're focusing on auditory and listening input as a sensory modality, the main sensory modality, but it's the core of auditory verbal therapy. So if you can explain more about that, please.
Can you hear me? Hi. So I was waiting for somebody to mention this. So yeah, in its essence, it does not contradict AVT, but AVT is in its essence is auditory for verbal. So I think it's semantics, really. So if you want to call it AVT, you can call it AVT. If you want to call it oral rehabilitation, you can call it oral rehabilitation. It's merely about picking the strategies that you want to use. If a person saw that session, they wouldn't call it an AVT session. They would call it language therapy with an AAC tool. But my emphasis in calling it AVT is because I want to emphasize that we're still working on auditory skills. So I'll give you another example. This child is a bit far from AVT, but if you have a child who is typically developing, who has a CI, and you're doing AVT for like 6 months, and then you realize this child has apraxia, you'd still work on AVT strategies in an auditory and receptive language standpoint, but you'd have to include an AAC to support the lack of verbal output, if that makes sense. So I would still call that part AVT and that part AAC. So I get where you're coming from. I think it's really just semantics. We don't actually have something that calls the two of them. My issue with completely removing the concept of having audition as part of it is I'm afraid if we don't talk about auditory, we're going to forget to work on auditory.
Yes, so I was actually thinking if the same session, if with the same patient, you would use like the auditory first, if asking like أبغى موزة and then click on it. That would be more of an auditory verbal therapy with augmentative communication rather the other way around. And another thing, like when do you start with ACC from the AAS from the beginning, or you try AVT first for a bit and try to push and then introduce it after that?
I would argue against thinking AAC is a last resort, because that's what we usually think of AAC as. It depends on the case. If you have a typically developing child, they did very well pre-CI, you implanted them, you wouldn't go AAC directly. But if you gave them 6 months and then you're like, oh, this child has probably apraxia, I would immediately introduce AAC because this child is developing receptively. They can't keep up expressively. Well, if you have a child with cerebral palsy and you implant them, you know they're going to need AAC from the beginning. So it's very case by case. I don't think there are specific rules. You would try it. AAC mostly is trials, if that makes sense. You try it and then you know. I had a child who had BAHA and childhood apraxia of speech. So I was doing AVT for like 6 months to a year, and I thought this child had issues. I thought I had issues. What's going on? Why is he not picking up? I thought he had auditory discrimination issues. He didn't. He had apraxia. He wasn't able to say linguistic sounds because he couldn't say them, not because he couldn't hear them. The point where I realized that, I was like, I need to introduce AAC as an alternative tool. He didn't like it. He refused to use it. So we didn't use it. We tried it for a couple of sessions. It didn't work. So we were back to traditional AVT with the addition of apraxia therapy. So I would think of AAC more of like a child who has apraxia. When you want to do apraxia therapy, do you stop doing AVT? La. You do both. Do you get what I mean? Yeah. But I just want to start thinking of them together because when we do take courses in AVT, they're very hesitant about including gestures, signs, stuff like that. It's a very like red flag. خلاص, that you're doing something wrong. I don't want them to be thought of as something wrong, if that makes sense. That's my opinion. You can disagree. Yeah. What do you think?
Yeah, thank you.
Okay.
طيب, I think if there is any more follow-up questions, information, I think we can, and then we can close this session. Thank you all. Thank you, the speakers. Thank you for attending.